Okay, let's talk about glucagon. Glucagon is just that. It is glucagon. There's no other name for it. That's all we call it. It is a hormone or an analog thereof. It is of glucagon. It's the only one that does what it does. And its action is to elevate blood glucose levels through the conversion of glycogen to glucose and other factors. Okay? So its purpose is to elevate blood glucose levels through the conversion of glycogen into glucose. Also called gluconeogenesis. Gluconeogenesis. That's what happens in the liver when glucagon stimulates the conversion of glycogen into glucose to raise glucose levels naturally. So they have synthesized it to the point where we can now carry it on the ambulance and use it to treat hypoglycemia. And other, glycogen into glucose and other factors. But we are more concerned with the gluconeogenesis, or the conversion of glycogen into glucose. That is more of what we're concerned with than we are the other factors. Okay, so let's talk about that for a second. So we've already mentioned we're going to give this, we're raising glucose levels, so who would we want to use this for? Our hypoglycemics. Okay, also it is used in beta blocker overdose. So what do we know about beta blockers? Beta blockers slow the heart rate, and also by slowing the heart rate control blood pressure. So as a rate controller and as a blood pressure controller, if you overdose, what do you think might possibly happen? They're going to become hypotensive, they're going to become bradycardic, create some issues, correct? So in extreme beta blocker overdose cases, glucagon can be used as a treatment for beta blocker overdose. So now that being said, it is not a reversal. It does not reverse beta blockers. It doesn't even block the beta receptors. What it does is it is a workaround. Through the gluconeogenesis and the administration of glucagon, it works around the beta blocker to override its effects and until they wear off. Make sense? So no more beta blockers will be given, but they'll give higher doses of glucagon than what we would for hypoglycemia, or hypoglycemia. We're going to give markedly higher doses. Well, we aren't, but the hospital will, the physicians will, in beta blocker overdose. So for our part as pre-hospital providers, beta blocker overdose will be handled symptomatically. That's how we're going to take care of that. We don't carry enough on our ambulances of glucagon to treat effectively beta blocker overdose. So that's why it's worth mention here. Otherwise, we're just going to strictly concentrate on the hypoglycemia, right? So to treat the hypoglycemia, we are going to give 0.25 to 0.5 units IV. 0.25 to 0.5 units, and that is an IV dose, or 1 milligram IM. Okay, so now here's my feelings on glucagon. If we have an IV, why aren't we giving D50? Why aren't we giving sugar through the IV? Right? So what glucagon is going to do is going to convert that glycogen stores within the liver. Well, if you've got a person, say a chronic alcoholic or eating disorders or something like that that is very, very thin, very, very low body fat percentages, that kind of thing, chances are they're not going to have the glycogen stores that you need. So it's going to be less effective on those people, and you may not get any rise in blood sugar at all from the glucagon. And if you've got an IV, you need to be pushing D50. In that instance, it is a better option, and the effects are going to be more immediate, if you will. Okay? So, with that being said, let's go on. We've already talked about our dosage, 0.25 to 0.5 units IV, or 1 milligram IM. Our contraindications, of course, allergy to the drug. It's a hormone. Chances are they're not, but if they say that they have adverse reaction, well, why are we considering it? Because you want this to be this is going to be a severely symptomatic patient that you can't get a line on, in my opinion. Or if the family members say they have a reaction to it, that might possibly be something to consider as well. Also, are we going to give this in a hyperglycemic patient? No. So let's just it seems painfully obvious, but let's go ahead and say it anyway. We're not going to give it to somebody with high blood sugar, okay? Because there's somebody out there that may try. Okay, so our adverse effects, there's none. There's none in the emergency setting. None in the pre-hospital setting. Let's call it what it is. It's either going to work or it's not. They either have glycogen stores to convert into glucose or they don't. Okay? This is also a fairly slow process, especially when given IM, so you're going to have to give it time. You can give this, load the patient on the cot, don't delay this, get them on the cot, and then transport to the ER. They possibly might be coming around by the time you get to the ER if it's going to have effect. Again, less effective. In patients with low glycogen stores, such as chronic alcoholics. If you can read that little scribble. Okay, again, less effective in patients with low glycogen stores, such as those found with chronic alcoholics, or very, very low percentage of body fat patients, where chances are they're going to have low glycogen stores as well.